the comprehensive management of inflammatory breast cancer, understanding the pathway to improved outcomes. Welcome to our in-depth discussion on the management of inflammatory breast cancer, a unique and aggressive form of locally advanced breast cancer. In this episode, we aim to provide a clear and comprehensive overview, tailored for both healthcare professionals and interested listeners who want to understand why the management of this disease stands apart from more common breast cancers. Why inflammatory breast cancer requires a unique approach. Inflammatory breast cancer is distinguished not by a single lump, but by the presence of cancerous cells that block the lymphatic vessels within the skin of the breast. This blockage results in hallmark symptoms such as redness covering a significant portion of the breast, swelling that causes the skin to resemble an orange peel, warmth, tenderness, an inverted or retracted nipple, and a rapid progression of symptoms, often within less than 6 months. It is important to note that this cancer is always at least stage 3 when diagnosed, and if it has spread to distant organs, it is considered stage 4. Given its aggressive nature, the traditional approach of immediate surgery is not effective and can result in quickly recurring disease. The multimodal and sequential management pathway. The foundation of modern treatment for inflammatory breast cancer lies in a carefully coordinated, multimodal sequence that is delivered by a specialized, multidisciplinary team. Let us walk through each critical step of this pathway. Step 1. Diagnosis and staging. The journey begins with a clinical diagnosis, as the rapid development of classic symptoms is highly suggestive of inflammatory breast cancer. However, confirmation through pathology is essential. This typically involves a core needle biopsy to verify the presence of invasive carcinoma. In some cases, a skin biopsy may be conducted, which often reveals the invasion of tumor cells into the skin's lymphatic vessels. Imaging, such as magnetic resonance imaging of the breast, plays a vital role in determining the extent of the disease. To check for spread beyond the breast, advanced imaging techniques like positron emission tomography, or a combination of computed tomography scans and bone scans, are performed. Additionally, testing the tumor for hormone receptor and human epidermal growth factor receptor 2 status is absolutely essential, as these biomarkers guide the choice of systemic therapies. Step 2. Neoadjuvant systemic therapy. The first and most crucial phase of treatment with curative intent is systemic therapy administered before any surgery. The goals here are to control the rapidly growing cancer, target microscopic disease presumed to be present elsewhere in the body, reduce the size of the tumor to make it operable, and evaluate how the tumor responds to therapy, a powerful prognostic indicator. The selection of therapy depends on the tumor's specific biological features. For individuals whose tumors express human epidermal growth factor receptor 2, a combination of chemotherapy and dual-targeted therapy, such as trastuzumab and pertuzumab, has revolutionized outcomes. Patients with triple-negative disease, meaning their tumors lack estrogen, progesterone, and human epidermal growth factor receptor 2, typically receive combination chemotherapy that often includes anthracyclines and taxanes. For those at higher risk, adding pembrolizumab, an immunotherapy drug, has improved the likelihood of a complete pathological response and survival. In cases where tumors are positive for hormone receptors but negative for human epidermal growth factor receptor 2, chemotherapy remains the mainstay due to the urgency for a robust response. Endocrine therapy, while less effective initially for this aggressive cancer, becomes important after surgery. Step 3. Assessing response. Once neoadjuvant therapy is complete, repeat imaging studies such as magnetic resonance imaging or positron emission tomography are crucial to evaluate the tumor's response to treatment. This assessment helps the team decide on the next steps in the management plan. Step 4. Local and regional therapy. Surgery follows as the next phase, with a modified radical mastectomy being the standard approach. This operation removes the entire breast as well as the lymph nodes located in the underarm region. Due to the diffuse and aggressive nature of inflammatory breast cancer, breast-conserving surgery, such as lumpectomy, is not recommended, as it carries a high risk of the cancer returning locally. Radiation therapy is mandatory for all patients, targeting the chest wall and regional lymph nodes to further reduce the risk of recurrence. Radiation typically begins 4 to 6 weeks after surgery, once the patient has adequately recovered. Step 5. Adjuvant systemic therapy. Following surgery and radiation, additional systemic treatment is aimed at eradicating any remaining microscopic cancer cells. For those with tumors positive for human epidermal growth factor receptor 2, Targeted therapy such as trastuzumab, and sometimes pertuzumab, is continued to complete 1 year of therapy. In hormone receptor-positive cases, long-term endocrine therapy, often ranging from 5 to 10 years with medications such as tamoxifen or aromatase inhibitors, is standard. For patients with triple-negative disease who did not achieve a complete response from initial chemotherapy, the oral chemotherapy drug capecitabine has demonstrated improved survival rates. Furthermore, for patients with human epidermal growth factor receptor 2 negative tumors and a genetic mutation in BRCA1 or 2 who have residual disease after initial therapy, the addition of the PARP inhibitor olaparib may be considered. Managing de novo metastatic inflammatory breast cancer. When inflammatory breast cancer is diagnosed after it has already spread to distant organs, the focus shifts from cure to controlling the disease, relieving symptoms, and prolonging life. Systemic therapy remains the cornerstone and is tailored according to the tumor's biological subtype. Local treatments, such as surgery or radiation, may be used to alleviate symptoms like pain, ulceration, or bleeding, but are not intended to cure in this context. Key challenges and special considerations. Rapid and accurate diagnosis is critical, as the symptoms of inflammatory breast cancer can easily be mistaken for infections like mastitis. Therefore, a high degree of clinical suspicion is necessary. Outcomes are notably better when patients are treated at high-volume centers with specialized multidisciplinary teams. Participation in clinical trials is strongly encouraged at every stage, given the aggressive nature of this disease and the ongoing need for more effective therapies. Comprehensive supportive care, addressing both physical symptoms such as pain and swelling and the emotional challenges faced by patients, is an essential component of the overall management strategy. Conclusion. In summary, the management of inflammatory breast cancer is a complex, stepwise, and aggressive process that relies on close coordination among a team of specialists. The modern approach, which begins with systemic therapy before surgery and radiation, has significantly improved survival for this once uniformly fatal disease. Ongoing research continues to refine these strategies, offering hope for even better outcomes in the future. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.